month, I'd like to introduce our moderator, Robert Hunt, who is the Chief Executive Officer for Dietitians Australia. And this topic is From Within and Beyond the Health System, Informing Clinical Prevention. And joining Robert as the panel, Professor Sharon Goldfeld, the Royal Children's Hospital, Melbourne, Angela Young, Queensland Children's Hospital, Dr Tanya Kelly, Chair of Queensland Clinical Senate, and Peter Button, Health and Wellbeing Queensland Register of Community Voices. So I think we're all here, our panel today. So as I said, From Within and Beyond the Health System, Informing Clinical Prevention, and Robert Hunt, the Chief Executive Officer for Dietitians Australia, is today's moderator.
Thank you very much, Loretta. This is working okay? Yep, great, because I just changed my mind. Where's Mark? That was just moderating. Have I missed him? These are amazing. I thought they were for translating Scottish into English. But they're actually just to project your voice. Isn't that amazing, Mark? Hey? It didn't work all that well for you because I didn't understand a word you said, but you did a great job. So a round of applause for my colleague moderator. And is Jay with us still, or is he? Is he here? Where is he? Or did we fly him over here and now he's gone off? Oh, he's doing some radio. He's not bunked off. No. Well, if anyone sees him a little bit later, if I don't run into him, let's just remind him that here in Australia we have a lot of things happening. We have electricity, we have running water. We also have recess at school and we have gyms. But what we're going to do now, before I introduce the panel and we get started, is I'd like to do a little wellbeing exercise. You don't have to get up. All you've got to do is make sure you can move your right arm. And when I tell you, I want you to put your hand out like that and raise your arm. Let's have a little practice. Everyone do that all right? Excellent. Where's my photographer? There he is. Now, I need an assistant. I need one that's dressed in red. Is there anyone in the room? Oh! So we're going to take a selfie. And I'd like my panellists to come and stand here, face back towards us and do the same thing. They told me I didn't have very much time, so I'm sucking up a bit of time because this topic's really quite tricky. No, Robin, you're over with us. So now just a little disclaimer. This is going to be published and sent to Jim Chalmers saying we want 5% of the health of prevention. Okay? So, ready? 1, 2, 3. What a beautiful crowd. So compliant. Now, for those people who are online, where am I looking? Am I looking up there? For you all online, I understand you've got a Q&A box, and we all know how to use one of those, okay? So type in there, 5% funding, please, Jim. And then we'll take a printout, and then Robin can work out all of the politics behind whether this will work or not. Ladies and gentlemen, thank you very much for staying with us for this session. It's going to be quite a tricky one. I have got a spare seat. So if there's anyone that's particularly wanting to come down to get into the debate, you're most welcome. The session overview that I've been given, which I will read you, is the session is designed to introduce the term clinical prevention and highlight opportunities within the health system to embed clinical prevention into daily clinical care. Exploring what needs to be done to support the health system to be more prevention-focused, the session will showcase examples of clinical prevention models of care currently being delivered in the community and identify what sectors beyond the health system can play a role in clinical prevention. The session is designed to provide the audience, that's you lot, with an understanding of why there is a need for a clinical prevention strategy for Queensland and how prevention is a key priority for the health reform agenda. Now, the panel met and we've decided our own agenda for today. So I'd like to first introduce, I don't think you did, Loretta, did you introduce while I was getting mic'd up? Can I quickly do it again, because they're pretty impressive people, much more impressive than I am. First to Sharon, Professor Sharon Goldfeld. Sharon is a paediatrician and director at the Royal Children's Hospital Centre for Community Child Health and Theme Director for Population Health at the Murdoch Children's Research Institute in Melbourne. Sharon has over a decade of experience in state government as senior policymaker in health and education, including holding the role of Principal Medical Advisor in the Victorian Department of Education and Training. Her unique career has seamlessly straddled research, policy and practice, with her cross-sectional approach ensuring her research is robust and of high policy and practice utility for greater translational success. And Sharon was recently awarded the inaugural Miles Medal for Excellence in Original Research that led to outstanding achievement in research impact. Very warm welcome, Sharon. To Angela. It was a bit long. I might cut a few of these out if you don't mind. We'll get a bit cut.
Feel free to cut mine out, Albert.
Oh, I've got to say something about you, Angela. Angela brings a wealth of experience to the role of Executive Director of Aboriginal and Torres Strait Islander Engagement. Prior to her current appointment, she was the General Manager of Policy and Research at the Queensland Aboriginal and Islander Health Council, where she was a strong advocate for health advancement of Aboriginal and Torres Strait Islander peoples. Welcome, Angela. We have then Peter Button. Peter, since returning to Brisbane in 2014, he's occupied his time through getting involved in a broad range of health service improvement projects, focusing particularly on empowering the patient or consumer to become more engaged and informed about their own health and well-being. In late 2021, Peter participated in My Health for Life group meetings at Albany Creek. His experience there encouraged him to take a more active control of his own health and well-being, joining an older age person's boot camp program for 6 mornings a week and achieving a loss of over 16 kilos in weight. That's worth anything, right? And these have brought a more positive and active focus to his work in giving back to the community through his involvement in a broad range of programs, such as Beyond Blue and Eat, Walk, Engage, as well as working actively with Health Consumers Queensland and the Consumer Health Forum of Australia. And welcome, Peter. And finally to Dr. Tanya Kelly. Tanya is the chair of the Queensland Clinical Senate, a body that provides strategic advice to the health system. She's an experienced senior clinician who has held clinical leadership roles for the past 10 years, most recently as Director of Anaesthesia. You know, there's a word that I could never say, and it was chrysanthemum, but I've got that down pat. And I was once an MC of another function where I had one of this lot in the panel, and I thought, right, I'm going to replace chrysanthemum with the profession. So Tanya is a senior director in chrysanthemums. Welcome, Tanya. Great introduction, was it? So, ladies and gentlemen, we've got some really interesting people here, but I really do want to engage you all because I think you've been a little bit too quiet. But we're going to explore 3 themes here. Firstly, we're just going to, given, and we've all been told this today, but we all knew it, given the current health outcomes facing our community and increasing rates of chronic disease across the whole country, we wanted to explore first what is the role of clinical prevention and sort of look at the definition. We then want to have a look at what parts of the current clinical environment can we activate to focus on prevention. And then I've got a couple of curlies at the end. So let's start off with what's the role of clinical prevention? Who would like to start off with that? How about you, Tanya? Would you like to start on that one?
I didn't go to the preparation meeting.
That's
why I got the first question. Hello, it's lovely to be here. I have been a working clinician and continue to be, clinically practicing to this day. Have been for some time, and the question of clinical prevention, I guess, is one that could be asked of clinicians, but probably firstly should be asked of consumers. And if health is about the consumer, then prevention's about the consumer. And I think one of the things when it comes to the question of clinical prevention is really what is it that the consumers need and want in the prevention space, and that there is a lot of clinical assuming and presuming about what is required in the prevention space from a clinician's perspective. And whilst clinicians do bring an enormous amount of experience and knowledge and skill in that space, I think that really should be led by the consumer voice. What we see in hospitals, where I mainly work, is that if you imagine the prevention through to, primary prevention, secondary, tertiary, and all the way through to sort of treatment, hospitals generally are in the break-fix space. And if you imagine the tension between the urgent and the important, the urgent tends to overwhelm the important, or sometimes the urgent and the important overwhelms the important. And in the day-to-day practice of the unwell person in front of you, that can often keep you down here in the break-fix space and less heading towards the prevention space. Where in the clinical senate currently in the preparation, and the reason for my missing the preparation meeting, in the preparation stage of our first 2,000 days meeting with the clinical senate. And that's very much a prevention meeting. But to give you an insight into the, psyche of clinicians in Queensland and probably more broadly, we had questions from those attending. I'm not really in the first 2,000 days space. I don't really treat kids. Is this meeting for me? Should I come? Not actually recognising that the first 2,000 days is this opportunity, a window of opportunity, a fantastic place to have a prevention discussion. Because of that, I think, assumption around the break-fix component, and if we're going to be talking about the first 2,000 days, we're going to be talking about clinical treatments and management of children in the first 2,000 days, and less so about prevention. So I think my summary to that would be that clinical prevention, there is a long way to go in the kind of the hospital-based thinking around what prevention is and how it's an issue for all of us, and that we all need to be part of it. And I think that should be a consumer-led process of growth.
Sharon, paediatrician, first couple of thousand.
I guess I qualify to be able to talk about the first
you might be able
2,000 days. So I thought it was worth sharing a couple of facts to just kind of position this conversation as well. And I think it leads directly into the sorts of things you've been talking about, Tanya. But let me just start by also thanking everybody here for allowing someone, Southerner, to come up here and share the panel with these amazing people. So thank you for that. I feel very honoured. There's a couple of facts that I think are worth noting. Number one, there's recent data that's emerging that would suggest for the first time ever this generation will not live longer than the generation before. And that's not, and that's socially patterned, which is not going to be surprising to you. And that's because of the kind of chronic disease tsunami sort of coming through the pipeline. So that's the first kind of thing I think to really think about. The second is we have a kind of healthcare system that will not be able to deal with the load coming through it, if that is going to be what we're talking about. And it's quite clear that from a morbidity load, the greatest morbidity load coming through is, for example, the mental health morbidity load, and we definitely do not have a healthcare system that's going to be able to manage that. And I was recently on an international panel, and there was somebody from the pharmaceutical industry, and these were all adult people. I was the only person who was a paediatrician. Interesting, I was the only woman, but anyway, that's a whole separate story. But by the end of it, everybody was talking about the importance of prevention, and if we weren't talking about prevention, we were kind of basically screwed. Second of all, if we weren't talking about children, then we weren't talking about prevention, because our fundamental ability to create a healthier adult population is actually starting with children. So it was really interesting to have that sort of perspective from people out of industry at the end of it all saying, yes, we need to be talking about prevention, yes, we need to be talking about children. And the third thing is, how do you orient an entire system toward prevention? But we have some really important healthcare tools or healthcare service tools, which are our universal and primary care systems. And that's not to say that hospitals aren't important for clinical prevention. Of course they are. But if you go out there, which is where people live, which is out in the community, they are consuming the primary and universal healthcare systems much more so. And in our experience, there is a real job to be done in working with consumers in terms of what their needs are, and working with clinicians at all levels in that primary and universal healthcare system to think about, number one, how we're engaging with families and listening to what families actually need. Number two, we're kidding ourselves if at the healthcare system we think we can meet all the families' needs, which we cannot. And number three, how do we then work with the social care system and the education system, which of course most kids spend most of the time in schools, not in healthcare, to actually listen to what people need and orient ourselves. And my view is that's what a real clinical prevention system looks like.
Thanks, Sharon. So lots of presuming, assuming, listening capability from a consumer's point of view. Peter, here's your opportunity to shine in the best panel discussion you'll ever have in your life, moderated by a fantastic listening moderator.
Thanks for that. But I won't outdo Angela, who's going to sing her response.
That's good to see.
I guess when you did my bio, I had a bit of a think about it, and at the moment I'm flat out and very tired doing consumer representation work. I'm tired because I'm really enjoying it, and this has been brilliant today. Thank you for the invite to come here, because it's really re-energised me and got me refocused. I'm also tired because some of the projects I've got involved in, I've been invited as a consumer, or put my hand up because I thought I was interested as a consumer to get involved, but found that I was only there to tick the box as a consumer. And that really peeved me off. And it's actually quite interesting because a couple of them I've decided I'd stay on because I have a really sick sense of humour, and I thought, right, you're stuck with me, and so I'm going to give you hell. So in our monthly team meetings, when I start getting the same old standard clinical responses to things like, I've just been involved in a telehealth research project where I, as a consumer, was also in interviewing consumers of telehealth and then giving support back and advice back to the telehealth planners. But then in the clinical group I'm in, hearing the clinicians all say, oh, telehealth is just the latest thing, it won't go any further. I've then had great fun over the next few months peppering those people to the point now every time there's a meeting and every time there's an issue, the first thing they do is say, from a consumer point of view, Peter, what is your perspective on this? So I think I've been able to turn them around a little bit. I guess consumer engagement for me is very important, that we get not only the public sector, but the private sector and the allied health sector together. It really concerns me when I'm involved in this area of work, that you've got the public sector that think they're better than anyone else, and there's always comments about, oh, the private sector, they're only in it for the money, and the allied health sector are sort of seen as the poor cousins, and the consumers are seen as the, oh yeah, let's just tick the box. There's actually a couple of projects that I'm really impressed with and really enjoyed getting involved in. So I think clinical prevention is about seeing the consumers as a very much an equal partner in the planning and the monitoring, the evaluation, the delivery of service.
Thanks, Peter. Oh, keep going.
You mentioned My Health for Life. Give you a bit of background. I was getting sick of myself late last year, probably more sick of myself than my wife was getting sick of me with COVID. But I was getting a bit bored doing the same old things, all these meetings online and so on. So I saw this ad on Facebook, which I don't get onto much. I saw this ad for My Health for Life. I thought, oh, this would be a bit of fun, just down to Albany Creek. So I trotted along for the 6 meetings. And I really enjoyed it and learned a lot out of it. What really scared the bejesus out of me was sitting there with a group of 20 people my age and older who were all bitching and whinging about how their arms were falling off or their backs were falling off or they had this or that wrong, and they really didn't know what to do. And I thought to myself, blimey, I live with a wife who's got 6 different chronic illnesses, and I'm healthy and trying to look after her and trying to keep myself healthy. About time I get off my bum and do something. So as a result of that, one of my action plans was to get involved in this, what I call boot camp, for 6 weeks to lose weight and get active. 12 months later, I'm still involved in that, not 6 mornings a week, it's down to 3 mornings a week, supposedly getting fit. But I'm finding my role there is listening to the other participants who are my age and older, most of them. There's an 82-year-old who's lifting, this morning was lifting 68 kilograms, which just blew my mind. I'm up to 60 kilograms and crying with pain. There are a couple of people there who have just recovered from removal of organs and replacement of organs and stuff. It really inspires me. But to listen to other guys and girls who are there and hearing what they're going through and then picking those messages up and taking them back to my work as a consumer has been really quite inspiring. So I don't go so much for the exercise, but to pick up the intelligence from the people on the ground.
Thanks, Peter. Angela, so consumers, windows of opportunity. I know you're very passionate about Aboriginal and Torres Strait Islander children particularly. Where's clinical prevention sit in all of that?
Well, the clinical prevention has been a key to Aboriginal and Torres Strait Islander health pretty much since people started talking about it in an open and productive way. I think we're on our 4th edition of the National Guide for Preventive Health Assessments for Aboriginal and Torres Strait Islander people, and it's broken down to age group. But unfortunately for Aboriginal and Torres Strait Islander people, it was a little too late, this prevention phenomena around understanding how to prevent the onset of chronic disease and how to empower families with the information they need to really make a difference in their long-term health journey. What clinical prevention for Aboriginal and Torres Strait Islander people is not, and that is absolutely not consumer-led. So what we're not doing is working with our communities and saying, what will enable your community to be able to live the longest, happiest, healthiest life possible for you, and how do we enable you to do that? What we're doing is saying, this is what our clinic looks like, this is what our hospitals look like, this is what our system looks like. How can we slightly modify that with your advice to try to get somewhere close to what your community looks like? And that is not how we're going to change any landscape for health outcomes for our most vulnerable. It really is about empowering Aboriginal and Torres Strait Islander communities, particularly young people, because our population is very young, to build the results and the frameworks and the health system that looks like how they want to look at, rather than just reframing what we currently have and hoping it fits somewhere along the line. The other thing that I would say is clinical prevention as a term suggests that prevention can only happen in a clinic environment. And what I think we've heard a lot today is to really have any kind of an impact on the ongoing tidal wave of chronic disease that we're currently riding is that we have to get out of the clinic. How do we partner with schools, justice, sport, community ambassadors, local cultures, and how they move and how they feel to actually genuinely have an impact on what the next 10 years of health should look like? And that means we have to get outside of our hospitals and outside of our primary care clinics and into sport and into schools and into communities and into youth justice, into adult prisons, and let's stop pretending we think we know the answer, but go somewhere where a genuine partnership is going to make a difference in what health looks like in the next 10 or 20 years, because other than that, it's really just a term.
So we're going to talk a little bit about what parts of the health system we can engage here, but I'd like to hear, we've heard from the panel about what they feel about clinical prevention. Are there anyone burning desire to make a comment about clinical prevention? If we could have the house lights up a bit, or does that cause you a problem with the cameras? If not, leave it. Right, there we are.
Hi, my name is Z, a health consumer. Hi, Tanya. So it's
Microphone
really,
just up a little bit.
It's really great to hear about co-design and involving consumers, because it's really important that when we make these services, they're made fit for purpose, and we're not doing it again because we've not included the people that they're being delivered to. But in terms of clinical prevention, our healthcare system is based on activity-based funding, so on sick people. And if you've got less sick people, then the activity goes down, so you get less money. So how can we sort of look at that in a different way? And is outcomes-based funding something that we can look at that would change that so that we're rewarding? And, earlier we looked at and talked about the fact that you can't really measure good health, and we're not rewarding that. But would something like outcome-based funding be an answer for that? And do we think it'll happen?
Absolutely agree with that, and I should say I'm at Children's Health Queensland, so part of the system. So I should fess up really early that actually my job counts on activity-based funding, and it goes against everything that I know about good policy. So if you want somebody to be healthy, then you stop getting funded for unhealthy, because it just prosecutes the same problem. I used to work in the employment system. It's exactly the same thing. The unemployment cycle depends on people being long-term unemployed. The longer term you're unemployed your clients are, the more money your job access provider gets. So it's a perverse incentive for health, and particularly for your very vulnerable communities. That's a huge problem, because is there any genuine system will to change how you deliver care if actually having really unwell people on your books actually gets you money? What can you do to change the system or the culture? Because then you lose revenue, which means you can't have the people to deliver what you really need to do. So I couldn't agree more.
Any of the other panel like to make?
I was just going to say, there's this kind of unnatural tension when you start talking about prevention and hospitals and the way hospitals are funded, and then the way community systems are funded, which is actually a bit different. So I think one of the challenges in this space is to be able to be clear about where the greatest, bang for your buck would be in terms of prevention. Let's just drop off clinical for a minute and just talk about prevention as the kind of better utilisation of the existing service system. And let's not pretend, of course, that things well outside the service system will have even a greater bang for your buck. The social determinants, are going to be really vital for any sort of equity agenda. But if you think about some of those universal services, they're kind of activity funded, but they're kind of not. And some of it is about people coming through the door, which is actually quite important for people to come through the door. And a question about who's not coming through the door might be very important. And I'm really interested in I think outcomes-based funding could be okay, or it could just be the road to hell if you pick the wrong outcomes and you never shift them and everybody just kind of loses the will to live. But if you can find some... is it afternoon? I kind of lose a bit of frontal lobe after in the afternoon.
We've got some of that. We've got some of that breakfast whiskey to come forward. I think someone was going to get it.
I think it's nearly 5 o'clock in Melbourne.
Yeah,
so
it's
I'm
still
good to go.
breakfast whiskey. I'll drink it now.
And so what I was going to say is, I wonder if the metrics are really about how do we provide equitable access, high quality services to people. I'm interested in those metrics because from a prevention point of view, if we can make sure that all the families that we think are really important to walk through the door are walking through the door, you have to listen to families to do that. You can't do that any other way. And you have to have the metrics to tell you who's in your numerator and who's in your denominator. And then you have to look at yourself and say, are we providing a quality service? Are we listening to people? Do we know those metrics are in place? Is there a quality agenda here? Do we have those metrics in place? I would love to see a system, if you could tick, yes, we've got enough, yes, it's good quality, yes, everyone's coming, I'd be happy with that. And I reckon that'd translate to outcomes, but I'd be worried that if you just had outcomes, everyone would go, what the hell do I do tomorrow? And I think that's the question we should ask services to ask of themselves across the board.
Thanks, Sharon. I might go to this gentleman here.
Yes, hello, I'm Kay Snyder and I'm from Bundaberg. Question for Peter, but anyone else can answer it. I was just on my iPhone and I wasn't checking what's happening on Facebook. I was actually trying to ensure that what I was going to say is accurate. Health literacy amongst the Australian population indicates that 60% of Australians do not have the health literacy required to make good decisions about their own health. As someone representing the consumer, are consumers happy about that?
Probably not. The bugbear that I have is that a lot of the health agencies like to keep the information to themselves. Information is power. And the more I get involved as a consumer and start to unwrap them and unravel them and shake their doors, and get the information open and share, I find I get more excited with working with those agencies, because we not only explore more, but I like to push the barriers a bit and say that consumers should be involved at every level of the organisation, and by being involved at every level of the organisation, you're going to improve health literacy, because it's the consumers that will get out and provide information back out to the community a lot better than, say, all the publicity and all the collateral that you spend money on.
Angela?
I'll have a go at that one too. I think health literacy is another one of these terms I think that the health system has created. What does it mean? Who created it? And actually I would say that every person in this room has incredible health literacy depending on what their social circumstances are. It's us trying to fit in a definition of what we think health literacy means. I mean, if you take my community, we've survived for tens of thousands of years, so it must be fairly health literate actually, because still surviving. We might not be health literate in terms of the definition of this particular system that we're in right now, but what health means to me and how I want to practice it and how I want to add value to it for my family is a definition that's really personal to me. So I think as a health system, we probably need to get a bit more diverse around what does health literacy mean, and how do we support different parts of our communities to practice what a health and long and happy life looks like, with the knowledge, sharing the knowledge with the tools, but also access to things that allow you to be healthy in your way. Yes, there must need to be some biomedical definitions around life expectancy and what physical health looks like. But I think we're probably a little too tight with the definition about health literacy. And I'd like to know who came up with that definition and what was their social construct, because it probably wouldn't fit anyone in this room today. So I think we probably need to be a little bit more generous in terms of what health literacy looks like.
So thank you very much for the question. I'd like to move on now. We are skating close to the end. The second part of what we wanted to talk a bit about was what parts of the current clinical environment can be brought to bear in a prevention sense. Someone like to tackle that, Tanya?
Yeah, look, one of the things that you all might not be aware of, not sure, depending on where you sit in the world of health, as to how distant hospital practice is from primary care, like really, really distant. If you go through training, whether that be medical, nursing, allied health, at some point there's a fork in the road. You go left or you go right, and that's it. The connection between the services sort of ends there, and then you're funded by a completely different funder, and the system works totally differently. The digital systems don't intersect really whatsoever, and there it is. Yet the consumer has an enormous amount of involvement with primary care, and from time to time might make their way into higher levels. I mean that in the sort of secondary, tertiary space, not better, levels of care in hospitals, and that makes it really difficult. And the way we've set our system up at the moment is to make it very difficult to enter into the walls of hospitals. There's only really two front doors, one being through the emergency department and the other one through long outpatient waiting lists. That's kind of how it is. There's a lot of pushing at the edges and trying to create more front doors, and there's lots of people working in various agencies to improve that situation, but that's kind of how it is right now. And so one of the things that we're interested in the Senate is a much more direct relationship between hospitals and primary care, and the ability, we're imagining a world where secondary prevention, not so much primary prevention, but you can see it through at the end of the tunnel here, where advice, back and forth relationships between primary care and specialty teams are happening all the time, and that instead of, I think I need a little bit of support from a specialty team about this matter, I'm going to ask you to wait for a year and to deteriorate on a waiting list before you can get in to see someone. In fact, I'm going to be able to pick up the phone or a digital service and interact with a specialty team straight away. Now that might seem impossible, but there are a lot of system barriers that make that really hard. It's not actually impossible in and of itself. So there's that really is where we see, from a hospital perspective, there being enormous gains in the ability to provide earlier intervention and help people to not deteriorate as they wait around to access care.
Peter, I'm going to come to you in a moment, but just to the audience again, I'm looking for where there's current opportunities in the clinical environment. So if you've got anything, share or questions, please have a think about them because I'll be coming out. But Peter, what did I hear then? Disconnect, system disconnect, different funding, hospital versus primary care. Is that rubbish? Is it working really well out there?
It's not working well, but there are some really good positives. One of the experiences I had recently was one of my local hospitals rang me and said, look, you're a consumer. You've been dobbed in by HWQld. Would you like to do a project for us? It'll take you a whole afternoon. I said, yeah, fine. What do you want me to do? We want you to go into this ward, introduce yourself to the head sister of the ward, take your phone with you and just record everything you see, everything you hear over the period of about an hour and a half. Everything from the physical impression, the colours, the lights, the junk in the hallway, the movement, the attitude of the staff, everything. It was a really interesting experience because I hate hospitals. Even though I have to take my wife quite regularly to hospital and visit her, I just hate them. Hate them with a passion. So for me to be asked to do that was quite an interesting experience. I really enjoyed it, but I ended up giving a report which in a lot of senses was good, but in a lot of ways was critical. And I thought, oh yeah, they'll just tick that off. But they've come back with a whole series of questions of, okay, how can we improve this? What can we do? Can you come and talk to our management board about this? And can we work out ways in which we can develop a program over the next 12 months as to improve that? That, to me, is quite impressive that they're prepared to do that.
Angela, disconnect funding model?
It would be silly if, from an Aboriginal and Torres Strait Islander perspective, I said, no, it's all very connected. It isn't, but at least in Queensland, I think we're on the right track with Queensland Health's Health Equity Agenda, which was co-designed with Aboriginal and Torres Strait Islander community. I think we're getting closer in terms of connecting the parts of the system that need to work together for the broader health journey. The Aboriginal community-controlled health services sector is the best part of the health system to deal with prevention and building the health framework for Aboriginal and Torres Strait Islander people, yet it's probably got the smallest funding in the country in terms of a part of the system. So yes, I think we're getting there in Queensland. Certainly at Children's Health Queensland, we've done some incredible things by partnering with community control and partnering with broader primary care. But I think we need to be brave and honest about what parts of the system do their bit best and be okay with letting some of that power and control go.
So there were...
Can I just add...
Absolutely.
Just a bit of an example, because we're looking for some examples here. There's two things, I think, that might be thought about. First of all, I'm going to keep going back to the universal and primary care system because, that's actually where a lot of people spend time. But it's also a system that tends to funnel people into what I would call a seek and refer. So I'm having a chat with you, oh, there's a problem, let's refer you on. So if we put prevention and early intervention together, one of the opportunities, I think, is to turn that system into a seek and respond system. So what are the sorts of tools in terms of both having the relationship with a family to be able to seek, so to have that conversation, and then what are the tools clinicians need to be able to respond? Because if we keep referring everybody into the secondary system, it's, you can't do that. There's just no secondary system, and it's a highly privatised secondary system. So that's the first thing about this kind of seek and respond. And the other is we kind of need an end-to-end narrative for our service system. So we tend to do this, and we do this everywhere, so we'll just do this bit of it, but we kind of need to stack the whole system and then say, okay, from birth, what do children need and families need? What do they need from healthcare? What do they need from the service system? What do they need about the places they live, the built environment, the parks? What do families need to survive? Maybe they need more money. And I think unless we're thinking in that way, we're not really doing big P prevention. It's a bit audacious, isn't it, to say this, but I wonder if we're just kind of doing little p prevention, but if we're fundamentally wanting to make a difference to our society, I think it's about those big P prevention. And then there are some really neat tools, right, that have come through. Like, I know you guys have been doing telehealth forever, but telehealth is a game changer for remote and rural kids if we can do it well and if we can be really innovative. So, for example, as a paediatrician, I have to have a referral from a GP to see a kid with a developmental and behavioural problem. The single biggest problem for kids, or morbidity load in kids, are developmental behavioural problems. It's not cancer, it's not any of those things, it's developmental behavioural problems. So the family has to find a GP, get into a GP, get the referral, has to make its way probably to me down in the children's hospital to go and see them. But if you're really clever, what would stop the maternal child health nurse, family child health nurse, to see that family and just come and talk to me directly? Well, we could do that. So I think there are innovative ways of us doing these things that are just harnessing the existing system and just being clever about the way we do things. And clever so that we can deliver on the big P prevention and not just the little P prevention.
Anyone out there that'd like to add to areas of the clinical environment? Oh, you've already had your one. The lady behind you there, I think. Or did you put it back down, you didn't want to ask? No, there we are.
Thanks. It's Victoria Chalmers from the Health Contact Centre, which is part of the Department of Health. This topic, we're in the space of a lot of prevention services and early intervention across a range of health topics and across age groups and across the geography of Queensland. One of our most common experiences is clinicians who perhaps don't feel comfortable to bring up health and wellbeing topics or have time to add it to their existing sort of consultation that they have about the topic that the person really came to talk to them about today, sort of that more immediacy. I suppose my question is really around how do we create space and also comfort level, a confidence for clinicians to be prepared to bring up some of the very hard topics like obesity?
Eeny, meeny, miny.
Are you looking at me because I have COVID curves at the moment? That's fair enough. Let me answer that question. No, I'm kidding. Look, I think it's about... we get this all the time with... sometimes clinicians feel uncomfortable to ask their questions about identification. So sometimes people, I just don't know the right way to say this, but the answer is similar. If we empower our clinicians to understand why they're asking that question and actually are supported by the frameworks to do something if the answer is help-seeking, then I think the question is more comfortable. So if you want to bring up things like obesity or lifestyle or other social economic determinants of health in those conversations, perhaps the clinicians are feeling uncomfortable to ask because they don't know what to do with the answer or why they're asking the question. So how supported do our clinicians feel with if this particular patient says to me, yes, I realise I'm morbidly obese and I'm really struggling with that because I'm depressed. If that clinician knows where to go to support that person, or there's a framework around them that says I can help you regardless of what your answer is, then I think the question becomes less uncomfortable. What we have at the moment are clinicians who are fairly isolated in their practice, so they're careful to ask questions that they can't resolve, or they feel like they don't have the resources to be able to support the person if the answer is answered in an uncomfortable way. So as long as they know where they're going, if the person is seeking help, there is framework around the clinician to be able to refer or provide something to that patient, then the question becomes less uncomfortable, I think. And I'm not a clinician. But when I've been asked that question before, no, I'm kidding. I get it all the time. My mum is a GP, she asks me that daily. So that's just how I know.
We're rapidly running out of time, but there are a couple of other...
Can I just have one? Because you're on the money, Angela. I think there's a lot to do with actually clinicians not feeling very confident that they know either what those core messages are or the core questions they need to be asking, or what they do with the information once they get the answers. But the other thing that's important, I guess, from a public messaging perspective and a broader conversation that's sort of the two-way dialogue between consumers and clinicians is that there's often an expectation on the consumer side that this conversation's about one thing and not about some other things. And so, there are times when we receive complaints that this conversation went off track and started to talk about things that I didn't want to talk about, that I found offensive or that kind of thing. So there is some nuance and skill in being able to raise things in a way where you can walk that journey, try to understand whether or not there's some openness for this discussion, whether or not there's an expectation on the other side of the conversation that this is coming or that this is a discussion we might be having. So, there are a couple of areas, I think, where that sort of impede that conversation from happening in a preventative sense, and one of them is a consumer expectation. I don't know if your feeling is about that one, Peter, but yeah.
So,
and we also don't have good data to course correct. So it's really interesting. You would be familiar with all the quality improvement stuff in hospitals, and that's because we were busy killing people, cutting off the right arm, wrong, leaving instruments. So there was this big drive. But it's interesting we don't have that same drive around using data to look at workforce practice, and it is so hard. Those below the line things of changing what people do on a daily basis is really hard. So it's kind of interesting that we talk about it, but actually the data you need to say, look, this is going to be really hard. Why don't you just ask one person this question and see how that goes and reflect on that sort of practice is really important, but there's no funding for that sort of work. So it's kind of each man to themselves. And yet if we really wanted to change the system, if we were in business and we wanted to change the system, that's exactly what we would put in place. But somehow for humans, in human systems, we don't have the same degree of attention to what's needed to change the actual thing that's going to make the greatest difference.
So there's a bit in that. We heard about funding issues, skills issues, confidence, time, a whole lot of things, and there's a big red light flashing. Robert, shut up, wind it up. So any burning questions? Any burning questions of the panel? If not, I think I'm almost on time, Loretta. So, ladies and gentlemen, please thank this amazing panel.